Hello, followers of Neuro Takeaway. Today we have the great pleasure of receiving another outstanding neuroradiologist in our channel, Professor Timo Krings. Timo is the chief of neuroradiology at the Toronto Western Hospital and University Health Network. He's professor of radiology at Toronto University, and he not only is he a diagnostic neuroradiologist, but he's an interventional neuroradiologist. And in Toronto, he performs the studies of interventional neuroradiology at the Sick Children Hospital, one of the most important hospitals for children in the world. He studied medicine in Germany at Haken. There he did his residency in radiology with Professor Armin Trom. Then he completed his fellowship in radiology, in interventional radiology with the legendary Professor Pierre Lajunier in Paris. And now from 2008, he has been in Toronto, leading the neuroradiology unit in the Western Hospital. Well, he has written several books, hundreds of papers, but he has a very interesting perspective, being a diagnostic and an interventional neuroradiologist. So without further ado, let's receive Timo. Wait a minute. Yes. Hello, Timo. How are you doing?
Excellent. How are you, Carlos? Thank you very much for having me here.
Thank you for accepting the invitation. Timo, having worked on both sides of the Atlantic, how do you compare interventional radiologists in Europe and in America?
Well, it was a privilege, and it is a privilege, having worked on both sides of the Atlantic, as in a way I was able to learn from both aspects of neuroradiology. In Europe, especially Germany, Switzerland, France, most interventionalists come from the diagnostic neuroradiological world. So have a very strong background in imaging and know a lot about how imaging pertains towards the treatment of neurovascular diseases. In America and many other places around the world, for example, Japan, most neurointerventionalists come from a different pedigree, i.e. they come from the neurosurgical or neurology pedigree, i.e. they have been trained in neurosurgery, they have been trained in neurology, and then develop into becoming a neurointerventionalist. And therefore, while the European style of neurointervention is more based on the foundation of imaging as it pertains towards treatment, the American style or North American style is often more towards the diseases and the patient. Also, I've realized that anatomy plays a larger role in the European style of teaching, coming from especially the background of Pierre Lajunier, as compared to the North American way, where techniques and new devices are more of importance. I believe personally that there should not be a dichotomy, like a split between anatomy, imaging versus clinical and techniques. But in order to become a good neurointerventionalist, I think it's important to be an all-rounder, i.e. Be able to combine both worlds. And I think that this is a unique opportunity, and this is why I believe personally that training actually at different centers across the Atlantic and at centers with different types of philosophies and approaches towards neurovascular diseases is of great importance.
Yeah, right, that's good. And as a disciple of Pierre Lajunier, which has become a legendary personality in neuroradiology. What do you think it was his most relevant legacy?
I think his most relevant legacy is indeed that with his untimely death, he told us that we have to take better care of ourselves. I know that this is not what you expect me to say, because everyone says that his legacy is neuroanatomy, and there's no question. Neuroanatomy was what he taught and where he was amazing. But I think that with his untimely death, he taught us something which is way more important. And this is that life is short, and there's only one chance we have in life. And it is important to take care of ourselves, because if you're just working and if you're burning the candle on both sides, it will not be good for your health. And so I personally believe that what we have to learn from him is that life is precious, and we'll have to take care of ourselves.
That's right. I agree, and I understand you. Well, changing gears to more clinical issues, what do you say to a young lady who comes to your office asking for advice because of let's say 5 millimeters incidental aneurysm at the ACOM artery?
That's actually a question that can easily now take 1 hour to answer, if we go into all the details that we have to consider when we think about treating an unruptured aneurysm. And to answer, therefore, this question, I would A, need more time, and B, I would need more data. I would need patient-specific data. I would need aneurysm-related data, and I would need treatment-related data. So, patient-related data. Is the patient of Japanese or Finnish descent? How old is the patient? Does the patient have other aneurysms? Did the patient have a previous subarachnoid hemorrhage? Is there a family history of subarachnoid hemorrhage? Does the patient have hypertension? Does the patient have an underlying collagenopathy? Then we have to look at the aneurysm. Is the aneurysm growing over time? Do we have previous images? Does the aneurysm have a bleb? Do we have maybe computational fluid dynamics, vessel wall imaging? Then I have to think about my risks of treatment. Up to now, looking at the patient and looking at the aneurysm told me what is the risk of rupture for this aneurysm. Now I have to look at the other side of the story. What is the risk of my treatment? So I have to see it. How tortuous are the vessels going up? Is it a wide neck aneurysm? Do I have to do X stenting, Y stenting, T stenting, flow diversion treatment? Can I put a web in there? So depending on these different factors, I will have to go towards a very individualized risk assessment for both the natural history and the risk for treatment. I will have to look at the FACES score. I will have to look at the data from the Izuya trial. I will have to look at the Japanese Izuya trial, and therefore tell the patient, according to these trials, your risk may be so and so much, so and so high. However, I also have to take into consideration that these studies are flawed studies. And the meta-analysis, like the FACES study, of multiple flawed studies will perform even a larger flawed meta-analysis. And therefore, I do not think that taking the FACES score or the Izuya trial should be our gospel. but rather you'll have to look at many other features that are not being looked at in the phases score, that are not being looked at in the Yasuda trial, and that are still very much of importance. That's a long story. A very short story or short answer to your question. In most young people with a 5 millimeter aneurysm of the anterior communicating artery, given the especially Japanese trial that demonstrated that ACOM aneurysms are at a significantly higher risk, I would presumably go for treatment simply because her lifetime risk will be higher. But seeing an aneurysm should not be a knee-jerk reaction to us as interventionalists of saying, okay, we have to immediately treat. We have to think a little bit about risks and the natural history and the risks of our treatment.
I understand. So it's like a more individualized decision, no?
I believe that this is very important for our day and age, that we are not putting every single aneurysm into one box. This is an aneurysm and therefore we need to treat, but have to look at the patient. We have to look at also how the aneurysm impacts his or her life in relation to how is her anxiety level and how is the anxiety level leading her to live differently her life. We have to look at whether she can still get health insurance, because some health insurers may be more reluctant to give an insurance to a patient who has an underlying aneurysm. So these are all items that we need to discuss, and therefore I believe that rather than us as physicians saying ex cathedra, this is what has to be done, you'll have to work together with the patient in a collaborative way to make a treatment plan individualized onto the patient.
Right. Moving on to stroke, how comfortable do you feel with the CT flat panel images to rule out intracranial bleeding in the angio suite?
I think it depends on your machine that you have, and it depends on the severity of the bleed. I suppose that if you have a very large parenchymal hemorrhage, even with the older generation flat panel CT images, you would be able to identify it. On the other hand, if you have a subtle subarachnoid hemorrhage, let's say following stroke thrombectomy, and you want to be sure that there is no evidence for like some subarachnoid bleed, for these you will need the more like the newer machines and the newer technologies. We are in the lucky position here to have a very new machine with excellent imaging that uses a slightly different way of performing the flat panel CT on the angio suite. So we are doing it in a butterfly rotation so as to remove artifacts at the skull base level. And this has always been a blind spot, especially for subtle bleeds within the posterior fossa. And I think with these new technologies, we are getting better and better. And the good thing is about competition is that if vendor A has a very good flat panel CT, vendor B will have one too within the next year or two. But, so I believe that we will be getting there. Yeah. And at one point in time, even identify the smaller subtle hemorrhages.
So now you are performing a standard CT before going to the angio suite?
Actually, there are certain instances where we now, in stroke, even skip this step. So let's say we have a patient who is coming from an outside hospital, which is 1 hour outside of Toronto. Patient had a CTA at the outside hospital. Okay. We see that the patient has a large vessel occlusion. Patient got TPA at the outside institution. Yes. And is now being shipped to us for stroke thrombectomy. In these cases, I typically send the patient immediately to our angio suite if the patient still has symptoms. If the patient has no symptoms and comes from an NIHSS of 20 to an NIHSS of 0 once he arrived, of course, we will have to do the CTA downstairs in the angio suite. Downstairs, sorry, in our CT suite. But if the patient still has symptoms, we skip the CT step, we bring the patient to the angio suite, we ensure that there is no bleed by doing a flat panel CT in the angio suite, and then we go ahead.
Interesting.
My only question for a patient who is shipped is, if the patient has still symptoms, do we have a bleed? And I think that this can be definitely answered now with the modern CTA, and this allows us to make the time shorter by at least 20 minutes, because rather than going from the ambulance to the CT and from the CT to the angio suite, the patient immediately goes from the ambulance to the angio suite, which chops up another 30 minutes. 20 minutes.
And speaking about a stroke, I would like to know what's your current protocol for children in the Sick Children Hospital regarding mechanical thrombectomy.
So children are not small adults, meaning that the diseases that cause a stroke in children are completely different from the disease mechanisms that cause stroke in adults. And therefore, treatment in pediatric stroke is not as straightforward as treatment in adult stroke. It starts off with the symptomatology. Pediatric stroke more often presents with epilepsy or even headaches or malaise, whereas in adults it presents most typically with a hemiparesis. A child who has a hemiparesis doesn't even realize that he or she has a hemiparesis and just continues playing with his good arm. And therefore, the parents may only identify the symptoms on a belated fashion. So diagnosis will be one major issue. The fact that patients often come in a belated fashion is a major issue for pediatric stroke. And then the third major issue for pediatric stroke, why we can't just simply say we do it exactly the same way as in adults, is that the causes for pediatric stroke are way more diversified as compared to adult stroke, where we have to look at the heart and the carotid arteries in most cases. Pediatric stroke can be caused by dissecting diseases, transient arteriopathy, vasculitis, cardiac issues, coagulopathies. And therefore, we'll have to think about what the underlying cause is to be able to work towards the best possible treatment. So for example, if I have a perforator stroke in a child, I would relate it to, let's say, varicella vasculitis. There is no point in thrombectomy in these cases. On the other hand, if I have a patient who has cardiomyopathy and who has thrown an embolic clot into the M1, for sure, this is a perfect case for thrombectomy. Therefore, I believe that for strokes in the pediatric age group, our first step has to be to have very good understanding about the cause of the stroke, the type of stroke, large vessel occlusion versus small vessel occlusion, and the exact timing, i.e. How much of the brain tissue is already irreversibly damaged and how good the collaterals are prior to embarking on treatment. But again, to make a long story short, if I have a patient who has, let's say, an acute dissection and who has thrown an embolus, or cardiomyopathy and has thrown an embolus, of course we would treat him or her just as we treat an adult, i.e. be as fast as possible, go in there and try to get the clot out in the fastest way possible.
Right, excellent. We do the same here. We have a lot of care because sometimes the outpatients comes to the duty with a stroke secondary to a vasculitis. So it's that in that context may be dangerous, no, to perform.
Yes, yes, I believe.
Regarding AVMs, I would like to know if you think that we can classify an MVM according to the Spetzler-Martin classification with non-invasive techniques? Is that possible?
Now, the Spetzler-Martin classification is a relatively simplistic classification based on three aspects: size, drainage, eloquence. And I think that it is very much possible, even with a good T2-weighted sequence, to answer this question. Size in its largest diameter can very well be calculated based on cross-sectional imaging. Eloquence can very well be determined based on cross-sectional imaging. And whether or not there's deep venous drainage can be evaluated on cross-sectional imaging to have a look at whether your internal cerebral veins are dilated or whether your vein of Galen is dilated. So I believe that for this type of very specific question that you asked, for sure, non-invasive imaging, even just a plain simple T2 TSE sequence can answer the question. However, the Spetzler-Martin classification does say nothing about the natural history of an AVM, and it says very little about the risks for treatment if we embark on endovascular treatment versus radiosurgery. And therefore, it gives only one piece of the puzzle that we need to determine whether we should treat a patient or not. When we are looking at an AVM here at the Western, we have a multidisciplinary conference of radiosurgery, open surgery, endovascular, and our neurology counterparts who play the role of like wait and watch approaches, because not every AVM has to be treated. And then we are looking at every single aspect of the treatment and of the natural history. So the radiosurgeon will look at different things as compared to the surgeon. The surgeon indeed will look at the Spetzler-Martin or the modified Spetzler-Martin scale, which can be deduced from as I said, from a simple cross-sectional image. The radiosurgeon will look at different aspects. He will look at the overall volume. So for this, we would need a volumetric scan, either a 3D angiography or a high-resolution T1 FSPGR sequence. He would look at whether we have points of bleeding or of higher risk of bleeding, i.e. intranidal aneurysms, venous stenosis. So for this, he would need a very good DSA, maybe with a 3D rotation. A radiosurgeon would have to look at whether there was previous bleeds, i.e. he would need a T2 gradient echo or susceptibility weighted sequence. A radiosurgeon would need to see whether or not we have high flow fistulous compartments, because they don't react very well to radiosurgery. So he would need, again, the DSA. From an embolization point of view, I would need to see whether we have en passage feeder versus terminal feeder, whether we have a single compartment versus multiple compartments, whether we have a single draining vein versus multiple draining veins, whether we have prenidal flow-related aneurysms. So there are different aspects that I look at an AVM as compared to the surgeon, as compared to the radiosurgeon. And finally, we have to have the neurologist or the conservative advocate for a patient with an unruptured AVM, who looks at items such as, is there edema surrounding an AVM that would make an AVM more prone to rupture? Is there intranidal clot formation within pouches? Can we perform vessel wall imaging as a surrogate parameter of inflammatory changes within the AVM, and therefore try to identify what are the future risks of rupture? Then the neurologist has to say, what are the clinical symptomatologies of the patient? Is the patient truly asymptomatic, or does he present with progressive seizures? And if he presents with seizures, is it related to hemosiderin staining and irritation of the cortex, or is it related to a disorder of the venous drainage, i.e. do we have a pseudophlebitic pattern, or is it related to the AVM being located in the temporal lobe? And therefore, we need to now have a quote-unquote holistic aspect of looking at the brain AVM from different walks of life, from the surgical walk of life, the endovascular walk of life, the neurological and the radiosurgical walk of life. We have to sit together and then see not only the AVM, but also the patient. Is this a 70-year-old patient who may have had this AVM for many years, or is this a 6-year-old child who just presented with a seizure? And then discuss amongst ourselves what would be our presumed treatment plan, keeping the Aruba trial in mind, but also keeping in mind that medicine is not only an epidemiological science, but medicine is also art. Medicine is the art of getting all of the information together and then trying to find the best possible solution for an individual patient with his or her individual AVM. I do not like treatment strategies that are one size fits them all. So I go into an apartment store and I have a size 50 and I buy myself a size 50 suit. That works for me, but it may not work for you.
Yeah,
it will not work if I continue living here in Canada and eat too many hamburgers and may need a size 52 at one point in time or a size 54. So I need to individualize my approach to a patient. And I think this is what we will have to do.
Right.
Not that one size fits them all.
How far are we from the use of target drugs to treat AVMs or vascular malformations in general?
That's an excellent question. I think in our lifetimes, we will see a significant shift towards targeted drugs. And there are already now a couple of really interesting pathways that we need to consider. For example, in patients with Klippel-Trenaunay, with vascular malformations of the skin, with vascular malformations of the liver, we have identified that certain drugs actually do lead to regression of these types of AVMs. And it makes sense that this not only holds true for those peripheral vascular malformations, but also for central nervous system vascular malformations. I think that there's significant work that is going towards understanding that most AVMs are related to somatic mutations. And our group with Dr. Radovanovic here from Neurosurgery has recently published in the New England Journal work that certain AVMs do have mutations in the KRAS pathway. So the thought process right now is that AVM formation and evolution can be explained by a two-hit hypothesis, i.e. that there's an abnormal regulation in the angiogenesis, and then the second trigger leading to the formation of an AVM. And the pathways that are being looked at are the KRAS pathway and the mTOR pathway. And there are drugs that can inhibit these types of pathways. So for example, there's now significant work going on with tramitinib for vascular malformations as an mTOR inhibitor. There are inhibition pathways on the VEGF pathways. For example, there has been work that was done at UCSF where in the mouse model, VEGF inhibitors, Avastin, were able to inhibit the formation of brain AVMs. But this is very much upstream of the pathway. If you're going further downstream, you can use sirolimus to inhibit the mTOR pathway. You can think about inhibiting notch 1 or notch ligands if you are thinking about the angiogenesis and arteriovenous specification pathway very far down the line. And what we just like last week did in a patient with a huge facial vascular malformation that was treated elsewhere and that has literally exploded because of a ligation, embolization, we are actually discussing with the patient, with our local ethics board, to treat this patient with tramitinib, i.e. rapamycin, to target the mTOR inhibitors and therefore to target the most downstream pathway of the VEGF angiogenesis pathway. Right now we are in the stage of case reports for compassionate use, but I do believe that with time we will understand way more about the genetics of brain AVMs, and therefore I believe that in our lifetime we will see a significant shift in the treatment of brain AVMs.
Interesting, very interesting. Lastly, I'd like to know some things about your opinion of internal carotid artery. For example, do you think that we can measure, according to the NASCET criteria, an internal carotid artery stenosis with non-invasive techniques as MRA or CTA? Because I have some doubts about that.
Again, I believe that with non-invasive imaging techniques, CT, CTA, even Doppler, you are able to determine the NASCET criteria. The question is, are the NASCET criteria what we should use nowadays? Because the NASCET criteria just look at the morphology of the plaque. In fact, at one aspect of the morphology, i.e. the percentage of stenosis. However, even from the NASCET and ECAS trial, we know that it's not only the percentage of stenosis that plays a role, but also the plaque morphology. Do you have an extulceration, yes or no? But what I think we have now realized more and more, and there has been landmark work of Bruce Wasserman and our group here with Dave Michaelis and Danny Mendel that looked at vessel wall imaging, that look at the not only the morphology of the plaque, but the biology of the plaque. And I believe that this is way more important to determine the risk of subsequent stroke as only looking at the percentage of stenosis. So, let me give you an example. If I have a lipid-rich plaque with a thin, fibrous cap, my risk of having a subsequent stroke, even with a 50% stenosis, is significantly higher. It's somewhere in the range of 20% within 1 year, as compared to an 80% stenosis that has a very thick fibrous cap and just a thick calcified plaque.
Right.
So therefore, the plaque composition is way more important to determine the risk of subsequent events, and therefore is way more important to determine whether or not we should go ahead and treat. And it will be more important to determine how we treat, i.e. whether we go for end arterectomy versus stenting. Because stenting will be more difficult and more dangerous in patients who have a lipid-rich core as compared to those who have, let's say, intraplaque hemorrhage. And as such, I believe that we should look more at plaques using vessel wall imaging and therefore determine the underlying biology, the underlying pathological mechanism of a plaque when we embark on treatment of these patients. We recently had like a 50% stenosis, and by NESET criteria, we wouldn't have treated the patient. However, he had multiple ischemic events, all embolic in nature, all within the same hemisphere. And when we did vessel wall imaging, we saw a very thin fibrous plaque. We saw a lipid-rich core. We did perform end arterectomy. We got the specimen, and we saw that indeed there was actually active thrombus building on this like very like low degree stenosis. And so we are living now in an age where it is less the percentage, I think, that matters, percentage of stenosis. It is less for aneurysms, the size of the aneurysm, but it's more the aneurysm wall that matters. It is for AVMs less the Spätzle-Marding grading, but it's more how the AVM reacts. And this is why I believe that imaging has truly a renaissance in neurovascular diseases. Because it's not only that we see the percentage of stenosis, the size of the aneurysm, but we use all of these new imaging technologies, quantitative susceptibility mapping that David Hassan is doing in Iowa, vessel wall imaging for AVMs, for aneurysms, for the carotid artery, a macrophagy imaging that will tell us how dangerous a lesion is and therefore how necessary our treatment is. And so I believe this is going back to one of your very early questions, so about European versus American style of giving, of coming into neurointervention. I believe that the perfect interventionalist is trained in both imaging and in clinics, because imaging is so important nowadays for patient selection.
Excellent. The last question, what advice would you give to a young radiologist that would like to become an interventional neuroradiologist?
Go for it. Do it. Just do it. Sorry. Like it's, in my opinion, an absolutely fascinating, rapidly evolving field that is highly relevant for the patient, that is extremely rewarding for actually the physician who is doing it. I mean, especially now with our possibilities to treat stroke for the first time. I'm still in a generation where we used to use TPA and urokinase to open up arteries, and we were standing there for hours hoping that the thing will get open. And nowadays we have the tools to, in more than 80%, reliably and safely open the arteries, and we see that our patients are doing better. So I can't think of another field that has over the past 10 years been like a more fascinating field in medicine with so extremely good outcomes. So I would definitely recommend anyone to go for this field. I also believe that there's always the specter and the fear of artificial intelligence taking over our diagnostic counterparts. And this is like an entire Pandora's box that I don't want to open right now. But it will not happen in interventional neuroradiology or endovascular neurosurgery or interventional neurology. Call it how you want to. The other advice that I would give anyone who wants to embark on this field is, although it sounds boring, but do learn the anatomy. Pierre Lagenius used to say, anatomy is the cheapest way to be safe, and there is some truth to it. It is extremely helpful. It is difficult, and you have to learn it and learn it again and learn it again, but it will help you in more than one aspect. It will help you to understand diseases, and it will help you to treat safely, especially when we are going into the entire field of dural AV fistulas, or brain AVMs, or shunting lesions.
Well,
Next advice.
Thank you very much, Timo, for your time.
I'm not finished yet. Sorry, Carlos.
Sorry.
I have more advice. Sorry. Learn from your colleagues. Because if you're only working by yourself, you will not get an open mind. And therefore, going to different places is really helpful. We recently had a senior neuroendovascular surgeon from Japan visiting us, and I can tell you I learned more from him than he could learn from me. But he made the effort to come here to see how other groups are performing treatments. And I do believe that this is really important. And this is also important that when you transition from fellow to staff, because once you are staff, you are allowed to do everything. You have the license to embolize everything, no? But you should ensure that you are working together with more senior colleagues. And there's no downside of asking other individuals for their opinion and for their help. Yes, it feels good that you can do something by yourself and you can thump your chest afterwards, but it's not fair to the patient. I believe strongly, and I have many occasions where I ask my other senior colleagues, Dr. Pereira, Dr. Agit, Dr. Farb, Dr. Nicholson, about their help and about their opinions and about their approach towards a difficult disease. And the final thing is keep curious. Keep yourself curious. When you see something new, don't just say, oh, I have no idea what it is. Keep this spirit of being investigative and don't get mesmerized by new devices, but get interested about the diseases and therefore try to keep an open mind. Sorry to extend a little bit, but I
agree, and we try to do that approach here. That's very important. So thank you very much, Timo, for your time. I think you have a very open mind perspective, and you've always have this approach, and I appreciate that. So thank you very much, and well, see you.
Hopefully, when all of this is over.
Bye-bye.